Welcome to our presentation on steroids, led by Professor Yasin Tayem. Today we will explore the various aspects of steroids, including their classifications, mechanisms, and clinical applications. Adrenal insufficiency can be classified based on etiology into primary and secondary types. Primary insufficiency involves adrenal problems, while secondary is due to pituitary issues or ATH deficiency. Primary adrenal insufficiency can be categorized by onset. Acute cases, such as adrenal hemorrhage, contrast with chronic conditions like Addison's disease. Natural corticosteroids are classified by action into glucocorticoids, like cortisol, and mineralocorticoids, such as aldosterone, each with distinct physiological roles. Adrenal insufficiency involves primary and secondary types. Primary is localized to the adrenal gland, while secondary involves inadequate pituitary stimulation, affecting cortisol production. Treatment of adrenal insufficiency, whether primary, secondary, acute, or chronic, requires hydrocortisone replacement to manage hormone deficiencies effectively. Synthetic corticosteroids are also classified by action. Glucocorticoids like hydrocortisone and mineralocorticoids such as fludrocortisone are used in various treatments. Steroids are categorized by potency and duration. Short-acting steroids like hydrocortisone have strong mineralocorticoid activity, while intermediate-acting ones like prednisone have minimal activity. Long-acting steroids such as betamethasone and dexamethasone are very potent with minimal mineralocorticoid activity. Fludrocortisone is a mineralocorticoid with a 24 to 48-hour duration. The mechanism of steroids involves binding to receptors, forming a dimer, and interacting with DNA to regulate gene expression, impacting various physiological processes. Glucocorticoids have significant metabolic effects, including gluconeogenesis, insulin resistance, and protein catabolism, contributing to conditions like hyperglycemia and fat redistribution. Glucocorticoids are potent anti-inflammatory drugs. They inhibit phospholipase A2, reducing the conversion of phospholipids to inflammatory mediators, thus controlling inflammation effectively. Glucocorticoids exert immunosuppressive effects by reducing cytokine production and affecting various immune cells, which is crucial in managing autoimmune and inflammatory conditions. Due to their anti-inflammatory and immunosuppressive properties, steroids are widely used in treating autoimmune and allergic disorders such as SLE, psoriasis, and nephrotic syndrome. Steroids have diverse clinical indications, including autoimmune diseases like SLE and multiple sclerosis, allergic conditions, and even enhancing fetal lung maturation in preterm labor. Steroids are administered in various forms: IV for transplant rejection, orally for chronic diseases, topically for skin allergies, and inhaled for asthma, demonstrating their versatility. Chronic steroid use can lead to metabolic and endocrine side effects, such as red stria, bruises, moon-like face, and hirsutism, resembling iatrogenic Cushing's syndrome. Steroid toxicity also includes catabolic effects like muscle wasting and skin thinning, highlighting the importance of careful management and monitoring during long-term therapy. Long-term steroid use can cause serious adverse effects, including cataracts, osteoporosis, and increased infection risk due to immunosuppression, necessitating cautious use and monitoring.